Makes her take it with that hand. And I'll show you just
Good to go.
how he did. Watch him supinate it and hold his thumb on that radial head. Yeah, that's what I was telling. Then they go right back to playing. Alright, I saw that and I thought that's cool. I'm sure I could have found one before, but it just happened to come across. You know, it listens to you all the time, so I guess that's why that came to me. Alright, so we finished the forearm, and now we're rolling into the hand. The hand we discussed a lot more. When we get down to the foot, there are layers and muscles of the foot. When we get to that point, we're not really going to even cover those, other than I'm going to talk about foot conditions and what effects they have versus all the muscles. But here in the hand, we need to go through these groups. And they're divided, we said, into, well, they're intrinsic muscles of the hand. But you have our thenar group, a hypothenar group, and then in the mid-palm, you have just an adductor muscle that we'll see. Then we'll look at lumbricals and interosseous. Once we get to that point, we're down to the end of this block. So they're set up similarly, the hypothenar and the thenar groups. And all they're going to change is whether we're talking about the thumb side or the pinky side. And the thumb side being the thenar side. So in the thenar compartment, you have three muscles: abductor pollicis brevis, right? So the short abductor of the thumb, and then you have flexor pollicis brevis, short flexor of the thumb. Remember we had a longus before, and then opponens pollicis, which is a muscle that's going to allow us to do this, which is more significant than you think, right? Opposable thumb. So together, they're the thenar eminence, and when you look at the motor branch distribution, the nerve that innervates all three muscles is going to be median. From here on out, as a generality, especially like once you get out of here and you're just in clinic, I always just think, now, it's really down the ring finger, I just kind of separate them. What I'm going to keep referencing is if you do the like spine side, right, this side, when it comes to sensation and motor innervation for these muscles, is median, and this side is ulnar, which kind of makes sense, because if we flip it over and we looked at our median nerve coming in, and then we had our ulnar nerve that was not in the carpal tunnel that goes above, and it innervates on this side. And that's going to hold pretty much true. And we're going to come back once and later and say, well, we can split our thumb off too and say, well, this is C6, C7, C8, and then you reference nerve roots. Right. I'll show you that as we go along, how splitting your hand like that can help you out. Here's a picture of your thenar group where we're just kind of looking at how they're set up over here. All right, now, here's abductor pollicis brevis. We're going to see that a lot of these have the same origin point. This originates off of the flexor retinaculum, the scaphoid, and trapezium. So we're on the radial side of the hand. And it's going to insert at the lateral side of the proximal phalanx of the thumb, out here. It's going to allow that to abduct the thumb and help oppose it. Now, some of the hand motions that we're not going to spend a lot of time talking about the difference between, well, what's abduction and what's extension, and right, that's an OT type thing. So I'm just going to tell you what these muscles do. Now, the reason I said that is because when you talk about helps oppose it, wait, it just took it into abduction. There's a combination of movements. The hand's very intricate in the way it functions. We're not here to get that deep into it. So, median nerve. Opponens pollicis is also originating off of that flexor retinaculum scaphoid trapezium. It inserts along the lateral side of the first metacarpal. And its job is to draw the first metacarpal medially to oppose it with pinky. It's going to bring it across. Bring it thumb this way. And also median nerve. And then flexor pollicis brevis, same origin, and then it's going to insert on the lateral side of the proximal phalanx of the thumb also, and sometimes some split towards the middle, towards the medial side. Whole job is to flex the thumb, which it says in its name. Innervation median nerve. So those are the three muscles. They're going to be named the same thing in the thenar group, our hypothenar group. It's just going to have, reference our little finger instead of our thumb. But in between them, this is not in the thenar group or the hypothenar group. This is adductor, alpha delta, adductor pollicis, which originates on the palmar side of the second and third metacarpals. It's going to originate here, and it's going to insert the medial side of the proximal phalanx of the thumb. It's helping to adduct the thumb, which is exactly what its name is, adductor pollicis. Median nerve, ulnar nerve for hypothenar, median nerve for thenar. In the middle, adductor is actually ulnar nerve also. So the middle of the pollicis, adductor, and it gets ulnar. And one of the things we see you have to reference when you talk about the adductor muscle there is an abduction. When you look at the thumb, just like every other digit, and every metacarpal phalangeal joint and every interphalangeal joint, every single one of these, we have ulnar and radial collateral ligaments. Right? Just like we saw in the elbow, you see in the wrist, you see in between. So every joint we have where you think about flexion and extension, abduction, is they have these ulnar collateral ligaments, just say collateral. And one of them that gets injured is the ulnar collateral ligament of the thumb. And it's called skier's thumb or gamekeeper's thumb. I don't know why they leave gamekeeper in there. I guess because I don't live in certain bubbles. Like we're all different. And maybe you do have developed. Maybe you know somebody developed. You got gamekeeper's thumb?
Yeah, I was from like pitch gripping training. I did too much.
See, that makes sense, but they say this happens when you're carrying your game home after your hunt, and you got the bag draped over the throng or whatever they call it, and it's putting stress on your ulnar ligament there, ulnar collateral ligament of the thumb. But where you see this more often is somebody's like snow skiing and they have poles in their hand, and they go down into the snow, and their hand continues to go, but that pole's going to stop, right? It's not going down to the snow that deep, and they'll pull that back. I actually would like to change this. Nobody listens to me, because 90% of the time I just made that percentage up. Almost every time I've seen this, guess where it came from? Baseball, softball catchers. Baseball, they're catching those high-speed pitches and they catch it wrong and it pulls their thumb back. They get chronic injury to it also, and then sometimes it can do a true skier's thumb after a fall does this. You rupture. Chronic laxity would be more of gamekeeper. Skier's thumb, they're actually going to tear it. They've got a little avulsion fracture here, if you can see it. I have problems on radiographs on small hand pictures seen when they go, oh, there's some soft tissue swelling there. I'm like, where? I guess I can see the thenar group. I put an arrow there. So I guess I can see the thenar group's a little more swollen, but once again, I need like a fingerprint on there. Oh yeah, I see that. See that every time. Alright, the hypothenar group, we're just going to switch the name of the side, we're talking about which digit, so now we still have an abductor, a flexor, and opponents. Now we're just going to call them digiti minimi. All of these will be innervated by the ulnar nerve, and when you compare them to the group they're in, they're now on this side. So here's abductor digiti minimi. It originates off of the pisiform. Remember the pisiform's that bone, one of your carpals that is right at the flexion of the wrist. Flex your wrist, you can find your pisiform bone. And then it's going to insert on the medial side of the proximal phalanx of the thumb. Abducts and flexes. Really, it's an abductor mostly, but it can help flex. Fifth digit also. Flexor digiti minimi brevis. Say that 3 times real fast, right? Is originating off of the flexor retinaculum, hook of the hamate, almost said hamate again, and medial side of the proximal phalanx of the thumb. Whole job is to flex the 5th digit. Ulnar nerve, and then opponens digiti minimi. Just like we saw on the other side, except this one originates hamate, flexor retinaculum, and then goes along the 5th metacarpal medial side. So it's going to help draw the metacarpal into opposition to the 5th digit. So you're going to use both your opponent's muscles to do this. Do opposition. Of course, we can do all of them. That's the main thing we're talking about between the 2 different groups. All right, lumbricals. When you look at lumbricals, they say they have a worm-like appearance. Another thing that I don't see, maybe I'm not visual enough, I don't know why they look like worms. They're unique in that they're muscles of the hand, but they're going to originate off of tendons. And if you remember back to flexor digitorum superficialis, flexor digitorum profundus, those 2 that had the campus chiasm where it went through, the lower one being profundus. This is another reason it's profound, is because these lumbricals originate off of them, and then they're going to just go into the extensory expansions that are on the posterior side of the hand. So they're actually more on the palmar side, but they insert into the extensory expansions. Right? Their job is to flex the digits at the metacarpal phalangeal joints and extend the interphalangeal joints. So it's like you're doing this. You know, you're saying always, you do the things, I'm like, how tall is that lumberjack? And you picture lumberjacks being really big, so that's the action of them. Flex the metacarpal phalangeal joints and extend the interphalangeal joints. So you know, how tall is that lumberjack? My lawyer. But I don't have one. She said she didn't see him in my contacts. I wish I did, that'd be cool. My lawyer would probably Saul. If you don't know who that is, you're missing out in life on the best show. Okay, 2 lumbricals. Now let's see if it fits with what I told you earlier. The 2 lateral lumbricals, don't ever forget that you're in an anatomical position. So the 2 lateral lumbricals are going to be innervated by the median nerve, so that still fits our Spock sign kind of split. And the 2 medial, because this is medial lumbricals, are going to be innervated by the ulnar nerve. So we can continue to separate the hand that way. When you look at lumbricals, we're talking about them originally. You saw this picture for the campus chiasm. They're going to flex. I'm going to just switch. Here's your lumbricals. I got a bigger picture here. Remember we had the campus chiasm, superficialis splitting, and then I mentioned earlier the lumbricals actually originate off of here. So they're going to insert into the tensor expansions. Those are those pink kind of connective tissue areas that are on the exterior or the posterior surface, but what we call our extensor surface. So that's kind of what they look like, and that's why once again when you move, right, some of them are bipennate. So I'm not going to ask you ever which ones are bipennate, which ones are not. I know some of y'all get deep into stuff. All I want you to know about the lumbricals is they flex the metacarpals, extend the interphalangeals, and the laterals innervated by median, medials innervated by ulnar. Sit. Okay, then our last muscles of the hand that we're going to look at, we have interosseous muscles, and there are 4, I'm going to tell you exactly what to know about these 2. There are 4 dorsal interossei and 3 palmar. The 4 dorsal interossei abduct the digits, and the 3 palmar interossei adduct, bring them back. So we're talking about, I'm going to hold it up like this, we're talking about are dorsal interossei abducting, the palmar ones adducting. Right, now that doesn't make sense to people who think about things deeply really quickly. I'm not one of those, but some people go, well, wait a minute. How are you doing that action when you're talking about midline? Truthfully, when you study the hand in detail, they draw an axial line down the middle finger, right? I'm just a kid. Down the middle finger, and when they talk about abduction and adduction in that case, they're really talking about going back and forth towards that midline. Don't get into that. You're not going to be occupational therapy. All of them are innervated by the ulnar nerve. If you're in physical therapy, I'd leave that in there because they study the ulnar nerve a little bit more than we do. As always, we're leaving a little bit of this hand stuff out. Okay. If you ever studied the hand in detail. Okay, so here's your palmar interossei. There's that axial line I was talking about. And you don't have to know the origin of insertions, just knowing that they adduct or abduct. That's it. So all I want you to know about them, once again, is they're all innervated by ulnar, but you're looking at abduction or adduction. Dorsal, abduction, palmar. Dorsal, abduction, alpha bravo. Palmar, abduction, alpha delta. That's it. And then I kind of put this down here towards the end because the anatomical snuff box is an area of great importance for us. So we're really going to define this out, because other people will as you go through courses. If you look at the anatomical snuff box, that's that area that if you do a thumbs up, not everybody sinks in, but you will feel a couple of tendons here we're going to discuss. And in between, there's kind of a divot. And I guess they used to put snuff in there, snip it, I don't know. Maybe so. Maybe somebody's like, well, I still do that. Maybe so. I don't know. Anatomical snuff box. We put that there. The radial artery lies in its floor. Right? Remember, we're anatomical, but I'm holding it up. So there's the radial artery. This radial styloid process off of the radius there, you can actually feel that in this region here. And then in the floor, if you palpate, if you put your thumb or your finger into the anatomical snuff box, you're actually mainly feeling the scaphoid. You know, we throw in there that you can feel the trapezium, but nobody ever talks about that. You can feel the scaphoid in the floor of the anatomical snuff box. And I know some of you are very familiar with this, others have never heard about it before, but this is a very important reason that we only care about the scaphoid that I'm going to explain to you. Radial nerve provides cutaneous innervation. You don't have to pick that up here because I'm going to have you learn the cutaneous nerve charts just like we did dermatomes. So. Okay. So if you have a fall on an outstretched hand, a Fuchs injury, you run the risk, just like that girl did when we were skiing, of fracturing your scaphoid. Okay. So here's the golden rule, the clinical pearl, the thing that will keep you out of court. In the military, you know, we're not going to get sued. In the civilian world, if somebody comes in, this is why that little ER clinic at the ski place didn't want to let her ski, is if you have a fall on an outstretched hand, or it doesn't even matter, if you have anatomical snuff box tenderness, patient comes in, they have an anatomical snuff box tenderness. No matter what they did, they often reference they had a fall on an outstretched hand. They have to get an x-ray, or if you don't, and then scaphoid fractured, you're probably going to be sued if you didn't get the x-ray. Because I'm about to show you on another picture, the scaphoid has a very unique blood supply. And if they have a fractured scaphoid, if you ignore it, part of that bone is going to die. And I'll show you why. I like to kind of point out those tendons. Remember, abductor pollicis longus and extensor pollicis brevis form this side of it. And then you have the extensor pollicis longus, which is the one that used the Lister's tubercle to make that abrupt turn. And so we can see those are the tendons that you're seeing when you pop that up, the thumbs up. So the blood supply to the hand is unique. So hold on, before I get to this, I want to show you. I didn't put a picture there of it, but when we look at the scaphoid, and it sits there. Again, this is a Palmer view. You can't see the with the tubercles. This is Palmer view. But your scaphoid sits here. Here's your radius. And they're not depicted in gray here, but what happens, I'm going to draw my own arterial scar through. And let's say the blood supply comes into the hand. Well, then the way the scaphoid gets its blood supply is it basically comes back to here. So there's no blood supply. In other words, my scaphoid is here. The blood supply goes into the hand, and then it provides an arterial branch back to the the distal portion of the scaphoid. The proximal portion doesn't have its own blood supply. That's important because when the scaphoid fractures, that proximal portion of the scaphoid will lose its blood supply and it will necrose inside of there and die out. And we even had students in here who had something put in there to replace it. If you don't have your scaphoid, your wrist function is done. You need that. So at the end of the day, I think I beat it up enough. I don't care how it happened. If you ever hear the words anatomical snuff box tenderness, they have a scaphoid fracture until you prove they don't. And how are you going to prove it? Take an X-ray. I always think, but then do X-rays always show the fracture that moment? No? She skied anyway. Wasn't fractured. She actually hurt because I was talking about this area, which is just fine. Okay. I need to put a picture in there of scaphoid blood supply. So, why didn't y'all tell me I'm running on the notes slide up there? Because I pulled that video. Y'all need it big, like big 2D. You know. Blood supply to the hand has ulnar and radial arteries, we said. I do not want you to study any other branches of arterial supply to the hand, other than the fact that you have a radial, you have an ulnar artery that enter the hand. Now, I put in some extra information. The ulnar artery divides into superficial and deep branches. That's as far as I want to go with it. But they connect. So let me rephrase it. The point I'm trying to make, and what you need to know, is the radial and artery come into the hand, and they, at one point, will create an arch, and then they will have digital branches that come off to the fingers. But the point is that the radial and ulnar artery are connected so that you have dual blood supply to the hand because of the arch. That's it. That's what I'm trying to spell out here. And so if you look at that, you can actually see that they form an arch, and then you'll have all these digital branches. So we're finishing out the hand, so we still got to cover what I've already looked at. Remember, I said that this side, this purple, is ulnar nerve cutaneous sensation distribution. It splits the ring finger, and then part of the back of the hand. Once again, you don't need this box unless you like to study it like I do that way, where I like to see. This slide for me would be, well, this is a depiction of the ulnar nerves, motor and sensory innervations, all in one. I like to see it that way. If not, delete the box off of there if you don't like that. Same thing over here with the median nerve. There's your median nerve distribution and muscles that go along with this. It's motor innervation. So in pulmonology, they used to, I don't know if they do it, it was when my old counselor I told you about, bless his heart, he taught pulmonology. Now he smoked like crazy, but he taught pulmonology. And anyway, he was doing ABG lab. I don't know if they still do it, but you got to do ABGs on each other. And I don't go to a lot of IPAP labs anymore because I don't have to. I got other things going on, or sometimes I just don't want to. Maybe I'll show up. I don't know. But I used to go to a lot of them, but you had to sign up. And I would be the first one to sign up for labs because I wanted to get the ABG lab. Because the ABG lab is my favorite because we set you down because you never had an ABG. It's not like an IV. You can feel that needle going into your artery, but you're doing a radial stick, right? And they would always, my favorite thing is when they go, they'd say the same thing. You all right? And you can see the color going out. Like, you all right? Like, yeah, I'm good. And here was the key words. If somebody said, it's getting brighter in here, or man, it's getting warm, or I'm hot, they're going out. So I like that lab. A lot of people, you'd always have 2 or 3 that were out for a second. And we wake them back up. I know, I'm a morbid person, right? Some of y'all enjoy that too. But I think if they're not doing that, I need to check. So they need to do that because you will kind of got to know how to do an ABG a little bit. It's something cool to know. It ties in other classes, right? Where you're doing pHs and stuff. We're going to need that arterial blood gas. But all I'm going to show you is Allen's test. Before you can stick a needle in somebody's radial artery, or any artery in the body, before you stick in, especially the hand, if you cut off the blood supply to the hand, that's not going to be good. I think we all can think that's a positive there, or what do you call it, a fact. So you have radial and you have ulnar. Some people do not have a good or non-existent kind of ulnar blood supply. And so the radial artery is providing all the blood to their hand. And if you go and stick a needle in it and you damage that artery, which can happen, you just cut off the blood supply to their hand. That's going to be a very bad thing, right? It's not something you're going to hide and put in the record later. You're running them down to the surgery suite. And so you need to test that. You test that by doing Allen's test. I'm not going to read through all this. I think I even put some pictures of how to do it. Great. You can do it for yourself, and I can kind of do it if y'all can see them. And if you watch, like your hand, pretty pedal for mine. If you take, you can do it right there at the desk. If you take your middle finger and your thumb and put it across to collapse where your radial artery is, just pick a spot on the other side that's probably your ulnar artery, and hold that down and sit there and clench your hand. It's supposed to be 30 seconds. Mine doesn't take that long. As you see how it turns color. Now watch, now what you're going to do is release the ulnar artery. And the color should come back fairly quickly. Y'all see it? Some of y'all probably have close to see. It comes back fairly quickly. If that's the case, the ulnar artery is patent and you can do a radial arterial stick on that side. What if it's not? You go to the other hand. Right? Because most people, if they did that in their hand, the color did not return to their hand, right? You check the other side. Because most people only have that difference where they don't have an ulnar artery that's really good on one side. It's very rare to have it on both. I mean, you're still going to check that side. But it doesn't mean you can't do the arterial stick. You just got to do it the other hand. So you use Allen's test to figure that out. That's all the... All right. I kept referring as we went along. I gave you like slides from the ulnar nerve, and I'd say, well, I leave the cutaneous sensation on here. But this is where I want you to study them. It's in the pictures. Right? Understanding. It gets to looking a little confusing, but it's really not. In fact, we're not studying all the little branches that come off of these nerves. Well, I'm just taking you back and saying, well, look at the cutaneous sensation and be able, this is definitely a study pig, be able to label where these cutaneous sensations are. But look at the names of them. The only way you're going to confuse a lot of these is to not remember whether you're talking about the arm or the forearm. Because would we agree, I'm just going to be a little facetious again, would we agree that this area is called the arm? Okay, we would, no we would. And so we have a superior lateral cutaneous nerve of the arm. Well, is that superior laterally? Yes. Superior on the arm, laterally. They're named for where they're at. Not all of them are as easy, but inferior lateral cutaneous nerve of the arm. The reason you don't want to mix them up is just now instead of superior, we have a lateral cutaneous nerve of the forearm. Medial cutaneous nerve of the forearm. We'll get into the hand in a second. Same thing over here where you have the posterior cutaneous nerve of the forearm. Now the medial cutaneous nerve of the forearm that wrapped around. And most of these, if you were given the diagram, you could pick them out just based on the words that they use for it. When you get into the hand, think about what I said was splitting the hand between ulnar and median, especially when you're looking at the palmar surface. When we look at this is a dorsal view, like this way, back of the hand. And so this is all ulnar, and then this is our radial nerve. So that's different than what I told you, and that's why I kept holding my hand up this way. If you were to take the thenar group, because all of you are like, yeah, I already locked that in, well, hopefully. And you said, well, all of this is median. Well, it is, and it wraps over the tips and the back of the fingers a little bit, but the posterior side of that, the dorsal surface, and up to the tip of your thumb, is radial nerve. And radial nerve corresponds with C6, and that's why I said most people, you hold your thumb, and that's a large distribution of C6. When I fractured my neck that I told y'all about, I broke my neck, and I couldn't feel I couldn't feel my thumb at all on the back side, but I really couldn't feel the tip. But I'm still not sure if I can. You know, anybody ever have nerve damage? I think I can feel the tip of my thumb, but it doesn't feel the same as the other one. Just never completely. It took a while for the whole thumb to come back. That's what I was saying when I stood in front of the EMT, police, paramedic, veterinarian guy that was there at Mission Ballpark, whatever he was. And I was saying, I can't feel C6. I could feel the whole distribution was just dead at the time, but it came back. Okay, if you flip around to the palmar surface, that in this ugly yellow color is our median nerve distribution, and then ulnar nerve over here. And then you can see some of the radial nerve here. I don't care, don't get confused, palmar branch. Well, is it in the palm? Digital branch, well, it's in the digits, still median nerve. And then back to our dermatomes, where we do have to pick up on these. Look at his hand. I guess it's a him, I don't know. And you go for, I just rethought that. C6, C7, C8. C6, C7, C8. Does that correspond? Yes. Looking at cutaneous sensations, which are peripheral nerve fields, is different than dermatomes. So when I say C6, C7, C8, most of that references the dermatomes. But that's also pretty true for once you fully understand it. Like, well, C6 is radial. Okay, well, that fits with that. If you know all of the nerve roots and where they're supplying, but we didn't study it that deep. Other than that, you just memorize pictures, right? Just don't memorize colors. C6, C5, T1, C8. Remember, T1 is the most superior dermatome of the thorax. It enters the upper extremities. On the posterior side, it does not. the T1 falls off at the axle. And so the posterior side's a little easier because it truly fits the whole C6, C7, C8. That's how you remember it. I used to have a lot of polling questions during, well, actually way prior to COVID. They bought a bunch of clickers. I don't know what clickers are for questions. Like you go to a conference nowadays, you can hit a little clicker, or you can do it on your phone. And they bought all these fancy clickers, and you would get one when you signed in, and I loved them. I mean, I had questions all over the place during my slides. Then they didn't pay the contract on the clickers, so they don't always, just like the internet. So they don't work anymore. And so I left for a little bit, and I came back to the VA to work again here, and I'm like, they still have the clickers? They're like, yeah, it didn't work. I'm like, well, the clickers don't work, or you didn't pay the bill? Well, we didn't pay the bill. That's what it was. And so I went and found, I forget if it was Socrates or something like that, where you could do it on your phone. And the first class was the last class I ever did it again, because I thought that's a great check on knowledge. Nobody knows what you answered. And you know what they did? They went and complained to their counselors and things. People came back to me saying the students are upset because they don't have the data to do that. Okay. I quit. Quit. And I understand at the same time. Because people living there, I assume everybody has unlimited data. That's obviously not true, I found out. So, don't all phone plans come with unlimited data nowadays? Is that not true? It's true. No, I don't want to. I was going to say, does anybody not have unlimited data? Anyway, we're not bringing it back. The point I was making is, and then during COVID on Canvas, you can do polling questions really well. So then I put them all back in. Then I stripped them back out class before last. So you don't have the polling questions in there because you got monotonous. But you should review, this was one of them though. You should review the regional anatomy PowerPoint slides prior to taking test 5, 6, and 7. Yeah. Everybody always says false. True. Those first 39 slides, the introduction to musculoskeletal, will show up on test 6 and 7. Remember I told you that before? Now I told you I'd remind you, now I'm reminding you. Make sure you review those definitions and things, especially those charts. I like to go back and just pull one out, kind of like a definition. Does everybody know what I'm talking about?
Yes, sir.
I know, you've already committed it completely to memory, just like everything else around here. And it'll never leave, so. So tomorrow, done a little early, tomorrow we're going to have the upper extremity lab. Not Walters, Ruggerio's doing his lab downstairs or upstairs? Is he upstairs? So we're in the same thing, we're upstairs. Upstairs, Walters used to do them downstairs and people would show up down there when I'm up here. And then we'll split it into 2 groups, 30 minutes apart. If you really, I can't have the room overwhelmed. You won't be able to hear anything. There's too many people in this class. Even half of y'all is a lot of people in there, right? And so I like to split it into groups of 30 minutes and 30 minutes because most people sometimes don't even spend the whole 30 minutes. That's up to y'all how long you spend in there. If you're 1 or 2 of you want to go to both groups, that's fine. Or if after both groups finish, you want to come back in and there's nobody in there, I'll still have the lab set up for a little bit, right? Don't show up. I did that once. I said the lab's starts at 10 tomorrow. 30 minutes. That makes it 11, right? By the time we're done with those 2 groups, and you come during that time, you gotta come and at least show your face in the lab, take a look at things. How long you spend in there is up to y'all, but then I said at 11, anybody that wants to come back in after both groups are done, somebody showed up at like 12:30, wanted to look at the lab. And I'm like, well, I already put it all away. If there's nobody in there by 11:15, I guarantee you that I'll start putting it away. But if you tell me you're gonna come and be in there at that time, or you just stay at 11, you stay there and look as long as you want. Fair enough? That lab's for your benefit, so. And I will, of course, be there going through, showing you some things, making some jokes. Matt already stole one of my jokes, so I have to come up with a different one. He's already faster than me on that, as y'all know. You don't know Matt in the front row yet. Yeah, who? I heard he hates memes, screensavers, he doesn't like a lot of stuff. Anyway, sorry, I'm holding y'all up. It is my time. Sorry, we're done. You got an extra hour, however y'all need to use it. I'm out of here. Y'all have a great day, and I will see you tomorrow.